Whether you're here to learn or connect with new old friends or feel supported by each other, we're just glad that you're here tonight. The foundation was started in 1987, and our goal is simple, and that is to help you live longer, healthier lives. That is why we're here tonight. We want to support you in every stage of your life. So we invited you here with this wonderful panel of experts from our area. We hope to open the conversation tonight and make you feel comfortable and hope to provide you with some education that you can take home with you. You may have noticed that we've been taking some pictures around here. I had my camera going and Brianne from marketing department was taking some pictures. If you're not comfortable being on social media or in any of our advertising, please let us know because we don't want to offend anybody here. As we move through tonight, please make yourself comfortable. We want you to feel like you can move around, help yourself with food, help yourself with drinks. The mocktail is back there. Use the restroom as often as you need. We will not get offended, so please be comfortable as we go through the night. I'd like to take a minute to introduce our wonderful lineup of doctors. Dr. Tran, do you want to stand up maybe? Yeah. Dr. Nancy Tran serves on our CGH Board of Directors. She's a provider at the CGH Menopause and Sexual Health Clinic. She's board certified by the American Board of Internal Medicine, and she's a Menopause Society certified practitioner. Thank you, Dr. Tran. Dr. Singh, we're so glad you made it. She was on call, so we're happy she's here. Dr. Twinkle Singh specializes in interventional cardiology. She sees patients at the CGH main clinic and in our cardiac cath lab. Dr. Singh is board certified by the American Board of Internal Medicine in cardiovascular disease and interventional cardiology. Thank you, Dr. Singh. And Dr. Jones. Dr. Marcia Jones practices family medicine at the CGH Lynn Boulevard Medical Center. She serves as board chair for the CGH Medical Center Board and is a provider at the CGH Menopause and Sexual Health Clinic. She's board certified by the American Board of Family Medicine, and Dr. Jones is also a Menopause Society certified practitioner. Thank you, Dr. Jones. And Dr. Song. Dr. Young Song specializes in urology. She is a urology physician and sees patients at the CGH main clinic. Dr. Song is a member of the American Urologic Association, the American Osteopathic Association, and the American Association of Clinical Urology. Thank you, Dr. Song. And Pam Capp. Pam is a licensed physical therapist at the CGH Rehab. She works at the CGH Locust Street Medical Center, and she specializes in pelvic floor rehabilitation. Thank you, Pam, for being here. Each of these ladies bring valuable insight and experience to tonight's conversation. Thank you so much for your time and expertise, girls. So as we move through tonight, we're gonna break the talk into categories with different speakers addressing them. Dr. Tran is gonna start with menopause, what is menopause and hot flash, followed by Dr. Singh with heart health and menopause. Dr. Jones will help us with brain health and musculoskeletal health. Try that again, Amanda. And then after that, we'll break for some prizes. We have some really awesome books that these doctors are recommending and some other things to give away. So stay tuned for that. After the break, Dr. Song will teach us about genital urinary symptoms, and Pam will help us with pelvic health. So please plan to stay for the whole program. It's going to be wonderful. We hope to finish with the grand prize and finish at 8. Again, make yourself comfortable and let's get started. So Dr. Tran.
All right. Hi, I hope it's okay if I can sit down because I don't think it makes that much of a difference since I'm pretty short. So, but if you can't see me, then I can stand also. So thank you again, everyone here for being here tonight. So we're so excited to have such a great turnout. We hosted our first event, like what Amanda said last year in Sterling at the Mercantile, and we had a very great turnout then too. So anyone here besides the speakers and the sponsors and the volunteers here last year? Well, thank you for supporting us again. So I would say most of our talk is very similar to last year, but I would maybe take it as a refresher course because you probably don't remember everything that you heard, but there might be some new information also. So we decided to host our second event because a lot of people were not able to attend last year, and also a lot of people didn't know about it. There's so much buzz about menopause and perimenopause nowadays, well, at least for me, and all my social media is all about menopause. So our goal here tonight is to provide more awareness of women's health and also the importance of not just managing your current symptoms in menopause, but also prevention of health further down the line and also increased longevity. So all of our speakers here tonight are very passionate about women's health, right? So whether it's providing menopause care, sexual health care, Dr. Singh with cardiovascular care, urologic care, or Pam with pelvic care. And of course, we're all women here, so how could we not be passionate about caring for each other? I don't see a man, but if you're a man, raise your hand. Oh, not, okay. So I'd like to take this opportunity to share my menopause journey, how and why I am up here talking to you tonight. So my career in medicine started many years ago in internal medicine, and I've been a hospitalist my entire career since 2003. I moved here in 2009, and I practiced hospital medicine at CGH, caring for patients who are very sick, hospitalized, and running codes and all of those things. And it's very odd for me to think that I have transitioned from working in the hospital to caring for menopausal women and helping them through this transition. It started with me having heavy periods. So about a decade ago, I started having very heavy periods. My cycles were initially very regular, and then it started becoming irregular. I would start having those menstrual accidents again, like, you know what I'm talking about, right? So, because, I never know when I'm gonna have my period, and then it was so heavy that I would go to the bathroom every hour. So that my husband would say, how could you not know? You've been doing this all your life, and how could you not know? And I would get very irritated, roll my eyes and say, you don't understand, like I can't predict when it's gonna happen. So that was very irritating. But I knew that was part of the menopause transition, but I didn't know how bad it was gonna be. So I just said, okay, just kind of go with the flow. Eventually it's going to end. And then about 5 years ago, my son started applying to college. He was my first son in college, and I got very stressed. Usually I'm not a impatient person or irritable person, so my personality started changing, and I thought that was a little odd, but I really didn't put it all together. Then I started having more symptoms. So I usually go skiing in Colorado, and I would, when I'm up there, I would get short of breath, I would get dizzy and nauseous. And I said, hey, maybe I just have altitude, sickness. And I just did that and never thought that maybe because I was bleeding so much that I was maybe anemic and causing those symptoms. And of course, I'm a physician and couldn't even figure that out, right? And then I started having more problems, right? So I started having sleeping problems. So I never had problems falling asleep, and that was really never my issue, but I would wake up at 2 in the morning. 2 in the morning was the time that I would wake up, and initially it wasn't because I was hot, I was just waking up, but eventually I started getting hot. I never really had the sweats like some of my patients have, but I would get hot, and then I would kick the blankets off and put them back on, and say, okay, not a big deal. So again, like just never putting it all together. So at some point I did go see a doctor. I went to see my gynecologist, and I said, hey, what's going on with my heavy periods? She did like an extensive workup, like, endometrial biopsy, a pelvic ultrasound, or a bunch of labs, just a bunch of things. And really she didn't find anything. I did have some fibroids, which, maybe caused my heavy bleeding. But she's like, well, I didn't find anything, but you can go on birth control pills, or you can have an IUD placed. And I was close to 50. So I was like, maybe not. Let me just think about it and kind of just let it go. because I was just very hesitant to do that. And then the final draw was when I started having some vaginal dryness. And then I noticed that my sex drive was going down, and then those wonderful orgasms I used to have weren't as wonderful, they were just taking a lot longer. So that's when I went back to see my gynecologist, and she said she really doesn't do much with women's sexual health. She said maybe there's a place in Chicago. And I'm like, okay, I'm going to Chicago, like really? But she didn't really give me a name, so I was just kind of doing my own research. And it really didn't bother me that much initially because I didn't have a sex drive. But it bothered my husband. And then because of that, it bothered me, right? So then I was talking to Dr. Song, and she's like, oh, have you heard of this Dr. Kelly Casperson's podcast, And You're Not Broken? And I said, no, I've never heard of her. So Dr. Casperson's a urologist, but she emphasizes a lot and does a lot in the women's sexual health world. So I listened to a couple of her podcasts, and then Dr. Song said, hey, there's a testosterone conference in Orlando, you want to come with me? And I'm like, testosterone, really? I'm a hospitalist. Why would I go to a testosterone conference? And so I looked at the agenda, and most of it was men's testosterone. I'm like, well, I don't really care. But there were 3 lectures on women's sexual health. So I said, fine, I'll go. So we went there, and then one of the breakfasts that we had, we sat with the speaker that was talking about the women's sexual health, Dr. Rachel Rubin. She's really big in the whole menopause and the sexual health world. So we met her and we took a picture. Of course, she's like a celebrity for us. And I listened to her talk, and after her talk, I kind of gave her my story, and she gave me recommendations as to what to do. So I took that back, gave it to my gynecologist, and said, hey, can you do this, blah, blah, blah. So she got me all fixed up. So when I came back, I was very excited about the menopause, and I realized that a lot of us, really most of us, were not educated on menopause and definitely not sexual health. So, we have medical staff quarterly conferences every quarter. So I did a presentation there, and I just wanted to bring that awareness that, hey, a lot of the primary care providers and even the gynecologists may not know a lot of this information. And then I started getting more interested. I talked to Dr. Stein here, our CEO, and said, hey, what do you think? Are you okay with me starting a menopause sexual health clinic? He was very, very supportive of that. And that's when it all started. I asked Dr. Jones if she was willing to join me, and she said, absolutely. And here we are. So we've been attending lots of conferences on women's sexual health, on menopause. We got certified, and we opened up our clinic in August of 2024. And here we are today. So I just wanted to share that with you. And then the reason I want to share that with you is that I don't want you to have to go through all of that, taking years to figure out that these are all perimenopausal symptoms, and feel like you're broken, like there's something wrong with you, and feeling like that feeling of I'm not myself. So right now I can absolutely say I don't feel broken, and I don't feel like I'm not myself. So what is menopause? So menopause, for most people who naturally menopause, is 1 year after your last menstrual period. So the time before your menopause is called perimenopause. And then a year after your period, that exact day is menopause, but really no one counts menopause, right? So anything after that is considered postmenopause. So when we use the term menopause, most likely we're using postmenopause. And once you are in postmenopause, you are forever postmenopause. Because I would hear some women say, hey, I went through that menopause, I'm done with menopause. Well, no, you're never done with menopause. Once you're menopause, you will always have menopause. Your bones will continue to deteriorate, all of that. So it never goes away. Maybe your hot flashes go away, but the menopause stuff never goes away. So perimenopause is that transition, that time before your period ends. And that is when things go crazy, right? When you start having a lot of symptoms. Some people call it the zone of chaos. So because your hormones are very chaotic, your symptoms are very chaotic, your estrogen level goes up really high, it goes down really low, you start losing progesterone, and that's why you're having all of these symptoms, the hot flashes, the mood swings, all of it, the low sex drive, all of it. There's 2 books that I highly recommend for those of you who are perimenopausal. So even if you're not perimenopausal, you pass that stage, you can still read it. But if you're definitely not, even if you're not perimenopausal, like you're in your 30s, I don't know how many young people are here, if you're not even there yet, you're gonna get there. So you might as well read the book and learn about it, right? So the first one is called The Perimenopausal Survival Guide. So this is written by an internal medicine physician. Her name is Heather Hirsch, Dr. Heather Hirsch. And Dr. Jones and I actually met her also 2 years ago at a menopause conference. So when we decided to have this event this year, I reached out to her and told her we're having this event. So she sent me a book that is signed, so we'll be raffling that off in one of the prizes. So the second book that I recommend a lot is called The New Perimenopause by Dr. Mary Claire Haver. She's really big in social media, but I trust her information. So not everyone will I trust on social media. So she's a really a good person that I would kind of trust. So I would say The New Perimenopause is a very good book. It just came out 2 weeks ago. I haven't finished the book to say, but I read most of it. So what I've read so far, I highly recommend. So I just would recommend something that I haven't read. So what happens to you in perimenopause? Because of the whole changes in your cycles, your cycles get chaotic, your periods can be really heavy. It's usually really heavy because you're losing progesterone, and then it becomes really light later on the end, and then eventually you just stop cycling. So all the symptoms that, they list tons and tons of symptoms during perimenopause, but I'd like to focus on the main ones. So what do we normally see? So you have hot flashes. So you could be sweating or not sweating, you just have that feeling of hot flashes. You can have night sweats, you can have sleep problems, both falling asleep and staying asleep. You can have mood disorders, you can have concentration problems, you feel like you're having new dementia, but it's not dementia, like your memory seems to be failing you. You can have, it's a whole host, like vaginal dryness, you can have low sex drive, you can have muscle joints and ache pains. So just a whole constellation of different symptoms that can happen during perimenopause. So if you went to your provider, your primary care provider, and say, hey, I have I feel like I have anxiety in your 40s, and they say, well, maybe you might have new onset anxiety or depression, and they might end up putting you on antidepressant medications. So if you go there and say, hey, I might have problems with concentration, they might put you on medications for ADHD or something like that. So it's very important to kind of be able to look at all the symptoms, and the more you know what to look for, the more you realize that this is probably perimenopausal and not a new diagnosis of something else. So what are the common misdiagnoses for perimenopause? So new depression and anxiety, that's kind of what I mentioned. So I do see patients that come in and they're on anti-anxiety or antidepressant medications. And I would say, how long have you been on these medications? So they might say 2 years. And I go back, hey, well, how long have you been having the hot flashes? How long have you been having your cycle changes? So it seems more that it's not new depression or anxiety, but it's actually because they're perimenopause. So instead of treating with an antidepressant, it's better for them to have been treated with some hormones, so that you're not just treating, like putting a Band-Aid on a wound, but finding out the root cause as to why you're having those symptoms. But I'm not saying that you cannot have new diagnosis of depression or anxiety during perimenopause, but a lot of it is probably secondary to your hormonal fluctuation. So the other one that I briefly mentioned is ADHD, which is attention deficit hyperactivity disorder, or ADD, just attention deficit disorder. So we see that a lot of patients may have some mild cases of ADD, maybe throughout their life, but they're functional, they don't need medications. Now they go through perimenopause, they start having more symptoms, they can't function anymore, they can't concentrate at work. And so they talk to the provider, they put them on ADD medication. And yes, it'll work, but really it could be because they just needed hormones and not necessarily an ADD medication. So sometimes that, I can't say misdiagnosis, but maybe not necessary to be on ADD medications, which might have more harmful effects. Fibromyalgia is a very big thing. The symptoms of fibromyalgia is usually a diagnosis of exclusion, meaning you fatigue, they have sleep problems, muscle aches, joint pains, brain fog, they call it the fibrobrain, headaches, mood fluctuations. So as you can see, these are all symptoms of perimenopause also. I'm not here to say that fibromyalgia is not a disease. It definitely can be a disease, but we see a lot of women get diagnosed with fibromyalgias in the 40s and early 50s. So maybe it truly wasn't fibromyalgia, maybe it was perimenopause all along. Another one is adrenal fatigue. So adrenal fatigue, you may hear about it on social media, maybe from functional medicine providers. It's really not a diagnosis that we can put down in our traditional medicine. But if you look up what is adrenal fatigue, you will see that their symptoms are very similar: brain fog, sleep disturbance, fatigue, irritability, low libido, low motivation, just very low ability to be able to handle stress. So like all of that, again, is very similar to perimenopausal symptoms. So one of the questions I frequently get asked is, is there a lab test for perimenopause? So there is no lab test for perimenopause. It is a clinical diagnosis based on your symptoms. Now, there is lab tests to confirm if you're in menopause, but if you're still cycling, you are not in menopause, but you could be in perimenopause. So, your symptoms could be all the time. It could be maybe just 1 week out of the month when you're cycling, because during that week, your hormones might drop and you might start having those hot flashes or those mood problems, just 1 week, a certain time of the month. So it can, because that's usually how it starts. It starts with mild symptoms and then eventually you get them all the time. So the average age of menopause is 51 in the US. The average lifespan of a woman in the US is 81. So if you do the math, you spend 40% of your time in postmenopause. That's a huge amount of time. So what I usually tell my patients that come in, I said, hey, this is the time for you to look at your life and how do you want to age? And how do you want to live? Like, do you want to extend your life and live longer? But if you live longer and you're really frail, you're in a nursing home, you're just sickly, like what's the point? Well, that's how I see it. So I like to, like if you're gonna live longer, you wanna live as healthy as possible with as much dignity as possible, right? So that's where we talk about prevention of diseases so that you can live longer, but also live more healthy when you age. There's a group of women, and I don't know, I just wanted to make sure that you're aware of that. So they are premature menopause. So these are a group of women who menopause before age 40. So if you menopause before age 40, whether it's natural menopause or because you had your ovaries removed for some reason, or if you had chemotherapy or radiation that causes menopause, it's a big deal because these women definitely have a lot of medical issues that can potentially happen in the future. So if you menopause naturally before 40, we call it POI, primary ovarian insufficiency. So these women have a much higher risk of death. So you increase mortality risk by about 30%, heart risk by about 30%, stroke by about 60%, dementia by about 60%, mood problems by about 50%, and osteoporosis and bone fracture also by about 50%. So make sure if you do or know anyone or you yourself has menopause before age 40, you need to see a menopause provider so that you can get started on hormones. And usually this group of patients, we have to start them on much higher doses because it's too early for them to lose all of their hormones. As far as another question that commonly asks is, how do you know if you are actually in menopause, if you've had a hysterectomy, if you have an IUD and you can't menstruate, or if you're on birth control? So some birth control, some people tell them to take it continuously so you don't menstruate at all. So in some cases, so for example, a hysterectomy, you can, a lot of times I just base it on, say, your symptoms. If you're having symptoms, we're gonna treat you anyway. So now if you're on birth control, the only way to check whether or not you're in menopause is you gotta go off the birth control and see what happens. See if you cycle again. Normally you have to wait 3 months after going off of an IUD or birth control when the hormones are gone to actually say whether or not you are in menopause. How long would these menopausal symptoms last? On average, about 5 to 7 years, but not everyone will have symptoms. So about 80% of women will have symptoms, only about 25% have very severe symptoms. And what happens during this phase when you're in postmenopause? So like I mentioned before, your estrogen level kind of fluctuates. It goes really high, it goes really low. Your progesterone level will continue to drop. And then your testosterone also will slowly drop, but the testosterone never goes away. So your ovaries make all 3 of these hormones, but your testosterone is also made in the adrenal glands. So when you go into menopause, most women will continue to make testosterone, but the estrogen, the estradiol specifically, and the progesterone usually just shuts down completely. Does the age of menopause matter? So we found that people who menopause later tends to live longer. So they have lower risk of fractures, osteoporosis, cardiovascular disease overall. So if you don't have to go into menopause, like, some people say, oh, just take out my ovaries. No, just leave them there unless you actually have to have a reason to take them out. So just kind of remember that. Like the longer, the later you menopause, supposedly the longer you live and more healthily you live. What are the factors that affect the age of menopause? I usually break it down into 2 different categories. One is things that you can change, and one's the things you cannot change. So you cannot change your genetics, your race and the age in which you start your period. But the things you can change is smoking. So if you smoke, it lowers your menopause age by about 1 year. If you had multiple, the more times you've been pregnant, the later that you'll potentially menopause. If you have a hysterectomy, you menopause earlier by about 4.5 years. If you had one ovary removed, you might menopause by about maybe 2 years. So those are the things that can change. Also lower BMI. So if you're very skinny, you might menopause early also. So the last thing I want to talk about is vasomotor symptoms really quickly. And vasomotor symptoms are the hot flashes, right? So this is like the hallmark of menopause. When women think about menopause, they think about hot flashes. So not everyone, again, have hot flashes, and not all hot flashes result in having sweats. So what is a hot flash? It's usually caused by a constriction or dilation of a blood vessel, and it's caused because your estrogen level goes up really high, it goes really low, so that dramatic change can cause your hot flashes. Also, estrogen controls the thermal regulation, the temperature center in your brain in the hypothalamus. The reason why when you lose all of your estrogen, it really affects the brain area and causes those hot flashes. What we know also is that studies recently, they just came out with a study a few years ago that they said that women who hot flash more might have an increased risk of heart disease. So not all women, what we don't know is if we cut back on your hot flashes by any means, whether it's hormones or other medication to reduce your hot flashes, will that improve your cardiovascular risk? And that we don't know. So they just need to do a lot more studies to figure that out. With this, I'm going to end and let Dr. Singh talk about the cardiovascular health.
Hello, hi everyone. So thrilled to be here and so nice to see such a great turnout. Okay. Congratulations to Dr. Jones, Dr. Tran and Dr. Jones for arranging this. And last year it was a success, and this year, yeah, wonderful. So when you think about menopause, the first thing that everyone knows that, okay, it affects your reproductive health, of course, it affects your sexual health, but there is actually such a strong correlation between menopause and your cardiovascular health, and it does not get enough attention. So much so that actually American Heart Association guidelines, they did not even involve that menopause is a risk factor for your cardiac heart, your heart disease issues until 2020. They knew that, okay, premature menopause increases your cardiovascular disease risk, but even just the natural menopause, it acts as like an accelerator for your, if you, whatever cardiac risk you have, it goes twice during even just during natural menopause. And we don't exactly understand fully why that happens, but there are several changes that happen in your body during this period. And when I say period, I'm going to refer to menopause transition. So that will involve your perimenopausal period, menopausal, and postmenopausal period. So this menopause transition period, it works as a risk enhancer. So what happens during this period, there is some redistribution of fat in your body. There is visceral adiposity increases, like the central obesity. So even if your BMI is okay, your waist circumference is high, that does not do as well, unfortunately. The other thing that happens, your lipids, your cholesterol levels, they increase substantially during this period. And not just the bad cholesterol, the good cholesterol, the HDL, it loses its cardioprotective effect during this period. So that's just another thing that contributes to your cardiac issues. And just other issues like your sleep disturbance, your mood swings, your stress, overall stress, that also increases your cardiac issues. Now, estrogen, it's such a great hormone. It keeps our blood vessels healthy. So as it drops in menopausal transition period, your vessels start to get stiff. So that increases your blood pressure. So all these factors, the combination of everything, it increases your cardiac risk. Okay. So, and why is it so important to know that that menopause increases your cardiac risk. So, and probably all of you know this. I'm not sure if you don't, then it's a great place to know that cardiovascular disease is actually the #1 killer of women in the United States, more than combined all the cancers. Okay, 1 in every 3 women will die of a heart disease, unfortunately. So we know that this period, it increases your risk, but we can think of it as like a bad thing, but also, look at it as like a window. It's a very critical window that if we implement certain changes during this time, then we can, improve our health going forward in our postmenopausal life. It's like a sort of like a turning point when it comes to your heart health. Okay. So, what should we do? First, it's very important to identify which women are at increased risk. Okay. So, #1, if your cardiometabolic health is not good to begin with, women who've had heart attacks or strokes before, you have high blood pressure, cholesterol, you're diabetic or smoker, these women, they carry higher risk of cardiac disease during this period. Then there are certain subset of women that may have not had any heart issues all their life, and as Dr. Tran was alluded to, that if your vasomotor symptoms, if your heart flashes, the burden of heart flashes, we know that is strongly, we don't know if it's causal, but we know that it's associated with increased cardiac issues. So if you have premature menopause, if you have surgical menopause, or by chemoradiation, then these women do carry a higher risk of heart disease during this transition period. So it's important to identify this subset of group. So once we know, okay, this is our group of women who's going to have more risk of heart disease, what do we do with it? Okay. So #1, it sounds very cliche, but diet and exercise. Okay. And by diet, I mean just eating clean. Cutting back on processed food, cutting back on stuff that's high in sugar and salt, decreasing the red meat consumption. Just eating healthy, cleaner at home. That's pretty much all you need. And by exercise, you do not need like a whole lot of exercise. AHA, American Heart Association, they recommend that all you really need is 20 to 30 minutes of mild to moderate intensity exercise, 30 minutes a day, and 4 to 5 days a week. And by mild to moderate intensity, just involves like walking, just a brisk walking at a higher pace. That itself is going to affect lower your risk to a greater degree. What are the things that we need to really focus on? So with women, I usually tell them that you have to know your numbers. You have to know what your blood pressure is. You need to know what your lipids are, what your A1C is, your BMI, your thyroid numbers. Once you know the numbers, you have the motivation to work on them. And once we know your numbers, we can work together to improve them. Okay. So and do our best, whatever we can, to optimize them. Like Dr. Tran was saying that there are certain things we cannot change, but there are things that we can change, and there are other things that we providers could test for to really assess your risk. Like coronary artery calcium score is a very good risk stratification tool. Okay, so we can it really is ordered for women who don't have many symptoms. If your calcium score is high, then we know that you are somebody who's at a higher risk of developing heart issues down the line, and then we can work more with you with your risk factors. Okay, so what else? Now, hormonal therapy, when it comes to heart issues, it's been a very up and down topic. Until like early 2000s, hormone therapy was prescribed like a lot. Then the WHI study got published, and they alluded that okay, the hormone therapy increases your heart disease risk. And but then lately, like in the second decade of the century, we had 2 good studies, and now we know that if you are a younger woman, if you are a woman who's less than 60 years old, if you're early in your menopausal journey, like within 10 years of your menopause, and you do not have any significant prior heart issues, then hormone therapy is perfectly safe for you. For rest of the group, it's an individualized decision. we assess what your risk is, and then we work together with you, with the primary care, with our menopause specialists, and decide what is the best kind of hormonal therapy for you. When it comes to heart, or more than the oral, is the transdermal formulations and vaginal formulations. They are relatively much safer. Okay. So I don't have a whole lot to add, but in summary, essentially, I just want everybody to be aware, and it's unfortunate that it's not just talked about enough. It's not taught in med schools. Like, we were never really. You guys can attest to it. Like, and it's such a significant. Every woman goes through it, and it's not talked in medicine. It's not talked about in cardiology. And we just need to know that it increases your risk, and this is the window that we can do everything possible in our power to optimize your risk factors so that you can have a healthier, better postmenopausal life. Okay, that's pretty much all I have. Thank you.
Thank you, Dr. Singh. It sounds like hot flashes affect the heart and the brain. Any of us have any brain fog going on these days? Dr. Jones is going to help us talk through that topic a little bit. And then afterwards, we're going to talk about musculoskeletal syndrome. So thank you, Dr. Jones.
Thank you. So I won't ask for a show of hand, but I'm sure there are some of us here in the room tonight who's probably been in the middle of a conversation. Before you know it, you've lost your train of thought. Or you walk in a room and you stand there and go, why'd I come in here? Walk back out and go, oh, I went for my keys. Well, we've probably been there, some of us, and some of you probably will get there, hopefully not too soon. But these are some of the symptoms that we see in women who have cognitive changes in the menopause transition. And when I mention that, we're talking about the perimenopausal phase through menopause and the postmenopausal phase. A lot of women are frazzled by this. They start having problem with retrieving words that they've used all their lives. There's difficulty in making decisions. Most women are the primary decision makers of their family for health, finances, and others. And suddenly, you can't make a decision. You cannot pay attention to things you would have done before. People are telling us that they're in the middle of meetings, they're distracted, they cannot complete a task, they cannot multitask anymore. It's like a brain fog. That causes fatigue, mental fatigue, physical fatigue. That can be pretty frustrating. We've got women who are wondering, have they lost their minds? And wondering if they have dementia, which for some of them, there are family members who they've seen go through the suffering of dementia, and it scares them to death. That's going to happen to them. Rightly so. Then we have libido issues. Most women who struggle with libido issues have had healthy sex life, and suddenly the desire is gone, the motivation is gone, the orgasm is gone. They may have pain with sex, which then contributes to the no desire and no libido. This then causes relationship issues. Partners think that the spouses are cheating, or that they're not good enough, or they don't love them anymore. So then there is strife in the relationship. And then we have these things called hot flashes. Those things that wake you up in the middle of the night. They disrupt your sleep. You actually have more anxiety because you're worried about when they're going to happen, and they're hard to deal with. Now, all of this happens not just because of hormones, but because of how the hormones affect your brain. So specifically estrogen. We know that estrogen is really called a reproductive hormone, but it's more than that. It's a brain hormone. It acts on many areas in our body, and in the brain, it's all over. We have gray matter and white matter. The white matter in our brain helps with the conductivity, electricity, how the messages get through. And the gray matter helps you to process. It's your executive function. It's like the CEO of the brain. When estrogen varies, fluctuates, and then leaves the building, these are being affected. Estrogen is helpful for letting the electricity or the messages get transferred effectively in the brain. It helps with the immune system, which then helps the brain. It helps the vascular system, which nourishes the brain, and it allows the brain to be more adaptable. And so when you have no estrogen, the brain is suffering. Progesterone and estrogen are helpful for moods. Progesterone is also a sedative effect. Estrogen is like nature's serotonin or Prozac. So whenever there is a fluctuation or an absence of estrogen and progesterone, then our moods are affected. Women are suddenly getting new onset anxiety. People who are level-headed and calm, and suddenly they're irritable. They've got rage and anger. People are telling us, hey, I'm mad at my kids, mad at my husband. They didn't do anything. I don't like myself anymore. I just don't feel like myself anymore. It's just not me. I don't like it. Estrogen also is helpful in how your body's processing your glucose and your insulin. And when that is not being regulated, we get a lot of visceral fat or belly fat. We get the cortisol belly, the high stress level. All of that is then affecting our mental health because we know it, we don't want to gain any weight, and we certainly don't want it in the midline. It's also dangerous for our health. We also know that there is amyloid protein that's regulated in the brain. And for people who have Alzheimer's disease, there's an extra deposit of this protein. And we also know that when this is not being cleared, then there's a higher risk of dementia down the road. They've done studies on women's brain in the premenopausal, perimenopausal, and postmenopausal. And there's actually structural changes in the brain. The gray matter and the white matter, there's a loss of volume. It's like it's shrinking. The energy, electricity, when they look at the PET scan, it's diminishing as well, all in this transition. The strength or connectivity is diminishing. The good news is it's not permanent. It can change. And when they look at these same women 2 years after their final menstrual period, a lot of this volume is replenished and it reappears. For the majority of women, it will come back. The problem is we suffer for years before it does so, and we don't really have to suffer. That's why we're talking about this tonight. We also see that women's verbal memory is the most commonly affected when they do test. So we have recall problem and concentration problem, but the verbal memory, the verbal recall is the most affected one, especially in the first 2 years after menopause. A lot of time we are asked, so how long is this gonna last? I wanna know. The average is 3 to 4 years. So there's light at the end of the tunnel. It doesn't have to be that way all the time. But there are other things the brain is helpful for that affects our health. And sleep is a big one. We find that during this transition, because of the hormonal changes, our sleep is affected because that increases the risk of getting sleep apnea, which is where there's obstruction in the airway. We sleep at night, we snore, we think it's okay, but we're not getting oxygen, which then makes us more tired, which gets into that cycle, that cascade that we're worried about. Women also have a higher risk of restless leg syndrome during this menopause transition. You're sleeping and your legs are moving all over, you can't rest well. That contributes to disrupted sleep or waking up in the middle of the night, as Dr. Tran alluded to, 3 o'clock. It's been studied. It's the most commonly hour that women wake up is 2 to 3 in the morning, where they can't get back to sleep. Women who had no difficulty falling asleep suddenly cannot fall asleep or cannot stay asleep, which is problematic. Then we have issues such as fatigue during the day, which is then disruptive to your actual overall performance. So if you are not able to sleep well, you're not getting adequate rest, you can't perform during the day, there's more mental fatigue, then that is definitely a cycle that contributes to more frustration, anxiety, stress, and all the things. What can we do about it? Well, we know that the first line therapy is hormone replacement therapy. And we also know that the earlier you start treatment in the perimenopause period, it slows down the change in the white matter and gray matter in the brain and slows down these symptoms that you're having. And if you're starting them early enough, it may actually eliminate any occurrence of these. So it's important that we take this time as an indication of looking into what our symptoms are and investigating what the treatment is. There are other issues that are arising too, and one of them is alcohol intake. We know that alcohol is toxic to the brain. And even one drink a day, which is acceptable in many situations for women, is toxic to the brain. And there are studies showing that the electricity or conduction through the brain is delayed because of alcohol use. And chronic alcohol use, in excess of 3 drinks or more per day for women, increase your risk of chronic changes in the brain that could be reversible, that can lead to dementia down the road. That's eye-opening, because we are all probably used to a drink or two at Friday when we want to de-stress. And we're realizing that's probably not as safe as it used to be. Another thing that is important is cognitive exercise. And that's where simple things such as Sudoku and puzzles and those things that may not seem to be as important becomes an exercise for brain strength and connectivity. Social connection is also important, where you're socializing with colleagues and peers, and that actually helps the brain during this transition. While the brain is having these issues, the bone is not to be forgotten. A lot of women have new onset joint pains and aches, especially in their 30s and 40s. They're coming up with no swelling, no redness, no indication there's an infection, but suddenly they have morning stiffness, achiness in the joints, especially the shoulders, the hips, and the knees. And one of the common ones we see is frozen shoulder. It can be one or both shoulder, and we know it's because the ligaments are positively affected by estrogen. Estrogen helps with lubrication of the joints. Estrogen helps with how the cartilage are being elastic and being able to stretch. So when you lose estrogen, you lose that elasticity, the joints get stiffer, the cartilage are not as elastic, and then you get the pain. It's very insidious. You don't wake up one morning and suddenly can't move your shoulder. It's a mild chronic pain, and then you have limitation in your range of motion, and that's when we have to call Pam here and say, hey, help me out. I can't move my shoulder, what can we do? There are studies that show that estrogen does help with that. A lot of women have been diagnosed with arthritis, and it doesn't mean you can't have arthritis at a young age, but it's not always the case in the younger woman. Dr. Vonda Wright, whose book I highly recommend, The Unbreakable, A Woman's Guide to Aging with Power, she mentions and coined the term musculoskeletal syndrome of menopause. And it's used so we can all have the same nomenclature to discuss this. Because women will be going to the doctors, like myself in primary care, with, my joint hurts. I don't know what's going on. I can't lift like I used to. I'm stiff in the morning. I know my grandma had arthritis. Do you think I have rheumatoid arthritis? What's going on with me? And they're being diagnosed with a lot of things, including, arthritis and rheumatoid. There's a study that suggests that a lot of women who have been diagnosed with diseases such as rheumatoid arthritis may have not had rheumatoid arthritis if they have something called seronegative arthritis, which means they didn't have a particular positive blood test. And they do need to do more tests on that to confirm. But that's been looked at in that a lot of perimenopausal women are being diagnosed with other things that are not necessarily the only thing going on. And some of this could be hormonal. Now, we're not saying you don't have rheumatoid if you've been diagnosed. We're just saying that, this does happen. We find that women who have musculoskeletal syndrome of menopause can have issues with mobility as well, because the joints are responsible for helping with our balance. And so if joints are achy and you're not moving as much, then your coordination could be affected as well. There's a higher risk of fracture. A lot of the pain and aches the women are having kind of leads to less activity. And if you're not moving as much, then you're not strengthening the bone as much. The loss of estrogen also causing bone loss. And bone loss is a silent disease. We find that over 10% of women are having issues with bone. 1 to 2% of your bone is lost per year in a woman in the perimenopause transition, even with doing nothing, just aging, and you're losing bone. And the average bone loss in the menopause transition is 10%. So as you age, your bones are getting thinner, you're getting weaker, you're getting frailer if you just do nothing because you have lost your estrogen. Each year, there is a 0.6% decrease in your muscle mass, so your muscles are getting weaker as well because the estrogen has been lost. By age 50, 17% of women will have osteoporosis. Osteoporosis doesn't hurt, it doesn't ache, you don't feel it. Most women will know they have osteoporosis after they've had an injury, such as a fall, causing a hip fracture. And that's pretty frightening. Not only is it severely debilitating, but at least 50% of those women will never regain their function as they had before. And you can see the impact of that. You're thinking about, does mom have to move in with me? Does she go to a nursing home? How do I care for her? And so it impacts the whole family, depending on how old the person is. Is it you? Can you care for them? It's very frightening. About 200 million postmenopausal women worldwide would have osteoporosis, and it's 4 times more likely in women than in men to have osteoporosis. So it's present in men too. Certain medicines like steroids can affect, your bone strength, and so that's the reason they think men will have it. But women naturally not having estrogen is a big risk factor. If you take medicines like steroids, if you smoke, if you drink, if you have a family history, if you're Asian or Caucasian, if you're thin frame, those things increase your risk for osteoporosis. So it's important to know what your risks are and to get screened. Now, when do you get screened? Well, we'd like to say we're getting screened at the appropriate time, which would be, when your bones are rapidly declining in the perimenopause transition. But unfortunately, it's not recommended to be screened if you don't have those risk factors until you are 65. And so we're missing some women who probably have osteoporosis, but we don't know because it's not approved to be screened. And hopefully, we can talk to the women who have risk factors and get them screened as soon as possible, because otherwise we'll find out when they have fractures, such as hip fractures. So a DEXA scan, which is a bone density scan, a painless test, is used to ascertain whether or not you have bone density issues like a low bone mass or if you got osteoporosis. If you do have osteoporosis, it's treated. It's the first line treatment, depends on how severe your bones are, is hormone. Estrogen is approved for low bone mass, or we call it osteopenia. The bones are getting weaker. It is not approved in the United States for osteoporosis. It is in Australia and the UK. But you would think that if the loss of estrogen is causing your bones to get weaker, that is hopeful that replenishing that would help. But it becomes a discussion with the individual woman as to how severe the bone loss is and what the best treatment are, because there are other medicines called bisphosphonates, which are bone builders that are used to help with treatment. Exercise is important, and the particular exercise for bone strength is a little different from what we need for cardiovascular. So when we look at health, we look at both. What's going to help your blood vessels? What's going to help your bone? We are breaking and building our bones every day as we walk, as we utilize our body. So we do need to build bone by resistance exercise, weight strengthening. So hiking, walking, lifting weights. And lifting weights, what's heavy weight for you? So the recommendation is, in addition to having those 20 to 30 minutes of exercise, you need at least 2 days a week of strength training. It's shorter reps, heavier weight that you want to lift up to. So you're going to start lower. And the idea is if you get to 5 reps with a good form, rep number 6, you probably won't make it, then you're good. You're not going to start there, but you're going to start lower and work your way to that. That's the exercise that's going to help with the bone strength the most. That's not to say the other resistance, like lifting, the resistance band and kettlebell and hiking and walking aren't helpful, but you need a variety of those. Diet and exercise is very important for a lot of things, but especially for bone building, that's important. As far as supplements are concerned, vitamin D is the supplement of choice for bone building. There's some data to suggest that excess calcium may not have good cardiovascular benefits, and so we encourage calcium in your diet rather than supplementing unless you have low calcium. That's determined by your provider. And we recommend at least 800 international units of vitamin D for most women, unless there's a deficiency that we can talk about. Tai Chi is a good exercise. It's not only good for bone health, but it's also good for mental health. So it helps your cognition and it helps your bone. So overall, watching your diet, your exercise, getting adequate sleep, looking for sleep disorders, addressing your cognitive symptoms early, getting an evaluation at least for hormone replacement therapy, having a discussion is all important to your cognitive, bone health, and muscle health. Thank you.
Thank you, Dr. Jones. It's almost time for a break, but before we do, I'd like everyone to look in your pink bags. There's some slips in there. If you got a bright pink slip, you either won one of these books, or we've got some fans over here. We've got a special secret surprise. If you won some books or a fan, please come up during the break. Also, I want to let you know that the bathrooms can be used, all the bathrooms can be used, so you can use the men's restroom during this break. So please, yeah, we've got control tonight. Wow. Yes, we do. And then also, we are recording this on Facebook Live, so if any of your friends couldn't come tonight, they could log on the CGH page and log on. And I think that's all. Oh, also, the doctors have a sign-up sheet back there by the mocktails. If you would like their offices to contact you for an appointment, please sign up back there by the mocktails before the end of the night. So let's take about a 15-minute break. We'll start again about 7:15. Stretch your legs, grab some food, and grab a drink. Thanks. legs a little bit? Feel better? Okay, just a couple announcements, and I'm forgetting. Brain fog. Yeah, brain fog. Oh, I remember. Okay, brain fog is real, you guys. A lot of you were questioning the titles of the books, and there is a list in your bags. So you all have every book that they're recommending. So please refer to that. Okay. Again, use the bathrooms. Feel comfortable. Grab some food whenever you want to, and here we go. Our next category is going to be Dr. Song. She's going to share with us about GSM, or genitourinary syndrome of menopause. So here we go. Thanks, Dr. Song.
Thank you very much. Okay, I'm going to stand up too. Is this on? Can you guys hear me? Yes. Hello? Can you guys hear me? Okay, that's better. Okay. So, hello everybody, ladies of the hour here. It's a pleasure to be here with my esteemed colleagues. Thank you so much, Nancy and Marcia and Dr. Singh. I'm Dr. Song. We get a sing-song situation here. And then Pam, and all my patients hopefully get to see Pam. So this is a wonderful panel. Thank you very much. So I think about menopause and I think about midlife. And then I just recently went to another menopause clinic or conference called Menopalooza. And they talked about midlife upgrade. And that's what we want right now. Okay, this is why we're here, because we want that midlife upgrade. I know everything you've just heard was a little bit depressing, but we're here to empower ourselves and change that trajectory to get better. So I have good news to share. When we talk about GSM, which is genitourinary syndrome of menopause, it's never too late to treat that. Okay, so it doesn't matter what age you are, you're gonna get what I call skincare for down there. Okay, so GSM refers to urinary symptoms, sexual symptoms, and vaginal symptoms, or vulvovaginal symptoms. And so when I talk about the vulva, I mean, I don't know, maybe we know what that is, but maybe we don't. So I was just gonna do a brief anatomy lesson about the vulva. We all know what the vagina is, and we use it to describe everything down there. But basically, when I went to a deep dive into the vulva, it means in Latin covering, okay? It covers us. It covers the vagina, actually. So when you think of the mons pubis, I don't know if you have ever heard that. It's basically like the bump right here. Thank you, Pam. Thank you. We just riffed together. So it's the skin right above there where where it kind of starts at the top. And then it also includes your labia majora, labia minora, the urethral opening, which is very important to me, and then the clitoris and the vaginal opening. So all those 6 parts, when I say vulva, that's what you're thinking of. And labia majora, minora, clitoris, of course, those are like really important tissues for sexual function. Okay, that was a side note on the vulva. So when we think about GSM, it also includes recurrent urinary tract infections, and who hasn't experienced a UTI? And then it also includes like dyspareunia, which means pain with intercourse, and overactive bladder symptoms such as urgency and frequency and incontinence, and prolapse. And Pam can tell us about prolapse later. So those are this encompassing GSM. And then, I mean, I can talk to you about physical changes, and I've seen a lot of vaginas, and I've also seen a lot of exams. And so I can tell you that while every vagina is unique and that we should all just love the body that we have, as we get older, these changes will be pretty consistent. So I kind of start to see like thinning, like paleness, less elasticity, like vaginal shortening, like dryness we talked about, less lubrication, maybe like decreased orgasm, that kind of sensation. And interesting, something I learned from last year, since last year, was that hypertension, you have, with hypertension, did you know this? You have more vaginal dryness, so I didn't know that. So another reason to know your numbers, like Dr. Singh said. So anyways, what's the good news? The good news is that the skincare down there basically means low dose vaginal estrogen cream. Has anyone heard of that? It's like, just like $30 a tube, I think, and this is how I prescribe it. I say, basically, if you're a woman over 50 or you have any vaginal discomfort, you should get vaginal estrogen cream. It's like, basically, it's like it's such a great treatment for GSM. Like about 50 to 80% of women will have GSM symptoms that go through menopause. And vaginal estrogen will treat like 80% of these women. So why shouldn't we be all on vaginal estrogen cream? So what vaginal estrogen cream does is, once you have menopause, you have loss of estrogen in the vulvovaginal region, and also there's estrogen receptors in the bladder. So once you lose that estrogen, you start to develop changes. And when you give topical estrogen cream back to that area, you start to regain that lubrication, regain that elasticity, the thickness, and helps with urinary symptoms like urgency, frequency, like I said, and especially if there's pelvic pain, which of course I always refer to Pam, you can put that topical lotion right there. I don't want to call it lotion, I just want to call it cream. So how I prescribe it is basically a 1 gram, which is like a pea-size amount on your finger. It comes with an applicator, but you don't have to use it because it's just an extra thing to clean, and you kind of want to use your finger to make sure it absorbs, just like skincare, eye cream, face cream, foot cream. So you wanna, once you put it on, you're gonna absorb, you're gonna make sure it absorbs. Okay, so wherever you need it in the vulvovaginal region, because usually like at the 6 o'clock position in the vaginal opening, that's where it gets thinnest. And unfortunately, like, with intercourse, you can tear and bleed, and just those are like all signs that, hey, I should just get some vaginal estrogen cream. And then another benefit is, once you have estrogen in the vagina back, something called glycogen comes back into your vaginal tissue, and that brings good bacteria called probiotics into the vaginal region. And that's what helps you protect against recurrent urinary tract infections. So if you know your grandma, your mom, your aunt, your sister, anybody with recurrent UTIs, I highly recommend vaginal estrogen cream like candy, like everybody. So that's what you should be on, right? All right. So yes, there's also things like vaginal moisturizers and vaginal lubricants. I'm just so into the vaginal estrogen cream. I haven't really delved into it. Maybe Dr. Tran has. But there are other brands out there that are recommended, but it's not really as good as vaginal estrogen cream. And you need to be on it consistently for about 3 to 4 months to really start to see benefit, okay? And, like I said, I have a lot of patients in clinic, and it will cure about 70% of women with recurrent UTIs, and it will treat at least 80% of women with GSM symptoms. So why not try it? It's not 100%. And some women, they're a little uncomfortable with putting cream down there. But like I said, we talk about this, we're very comfortable with this. So I think we should all just be very comfortable with this. Because this like, if you're embarrassed about it, it's time to not be embarrassed about it, because it really blocks care, and I feel like a lot of women are like, oh no, I don't want to put it down. Well, you just do it, right? You just have to do it. Yeah, so you do it at nighttime usually, but I actually think just do it whenever you remember to do it, because a lot of times I'll see patients back and they'll be like, oh, that cream, I forgot to pick it. I'm like, well, it's been 3 months, so I guess nothing's happened. So, and then, that's just how people just forget, and I'm a patient of Dr. Jones, and I forget too, so I have to do something. But, so I understand, compliance, we're just here to remind you what to do, diet, exercise, yeah. So another thing the last thing I wanted to share with you was vibrators. Again, something new I learned since last year. There was this OBGYN, she did a study in 2024. She had 100 women and 100 vibrators. And they basically asked them to use a vibrator for 5 minutes, twice a week, externally, and not to achieve orgasm, just to use it. And it actually helped with GSM symptoms, and it also helped with like sexual dysfunction. So with that pelvic musculature, I just want to pass it off to Pam, and she's gonna take it now.
All right, can you hear me? Hi, I'm Pam and I'm a physical therapist. I work primarily with pelvic floor, okay? And so when people ask what the pelvic floor is, what we are referring to are the muscles that sit at the floor of our pelvis, okay? There are 3 layers for women. These muscles are very important. They do a lot of functions for us. 1, they keep the doors shut. We don't want to be peeing, we don't want to be pooping ourselves. We need those doors shut. In addition, they help support everything from above. So as we stand up and gravity hits that a little bit more, we need that pelvic floor more active. We need to be able to use those muscles to support us. So every step we take, we're not dropping as we're trying to take that step. It helps us have orgasms. So when the vibration happens, right, our muscles are getting stimulated, and that is creating pelvic floor strength, hence the reason that they're probably doing better. And they also help us with blood flow to and from that area. So there's a lot of really important reasons that we need that pelvic floor there. What I like to tell people is when they come to see me, I'm like, I deal with pee, poop, and sex. Okay? That is what we talk about in my office. And people are like, okay, this is TMI, but I'm going to tell you this. And I'm like, nothing is TMI here. We will talk about those things because it's really important. And most of the time, none of us talk about this. This is not something we talk about with our friends or neighbors, right? And we only know what we do. We know our norms. And so one of the biggest things I like to tell people is, here's the norms for peeing in particular, because that's a large amount of the people I see. We should be peeing 5 to 7 times per day, okay? That's roughly every 2 to 4 hours, waking hours. I usually tell people you get to be about 75, I'll give you 1 at night. That's it, okay? When we pee, assuming our urine stream is good, we want it roughly 8 to 12 seconds. Now, how do you know if it's good? How do you know if that's normal? Well, we don't. Our bladder capacity is usually 400 to 600 milliliters. That's roughly 1.5 to 2.5, if I remember looking it up correctly. That's roughly what our bladder holds. So if you really want to know if you're holding for long enough, that you're not going too early or too late, that's roughly what we're expecting to come out, okay? Let's see once. In addition, I see a lot of people with issues with peeing, incontinence usually. There's urge and stress incontinence. There's also mixed incontinence. Usually it kind of starts, I always think of it like, after we had a baby or two, we have that little pee when we're jumping on the trampoline with the kids or when we're doing jumping jacks, right? That's a red flag. Hey, we're having incontinence, but we giggle about it and it's like, oh, I don't really pee myself. It's just that little dribble now and again. That's a warning sign. We're not using that pelvic floor adequately. And so we need to learn how to do that. And then usually what happens is we have more and more events like that. So then we start going to the bathroom just in case, right? That's a problem too, because now we end up with more urgency because our bladder gets used to being this full when we empty rather than this full when we empty. So that becomes an issue. And so we talk about all this stuff when you come to see me. I do work with people with incontinence of feces or constipation. We work on things like that. We do work with pain. So we were talking about dyspareunia. I talk today. We talk about that, and a lot of times there's a tension there. That pelvic floor is guarding because we are incontinent all the time and we don't want to leak, so we're hanging on for dear life, right? So when we hear that magic Kegel word, are you doing Kegels? Make sure you're doing your Kegels. Sometimes it's not so appropriate for us to be doing Kegels, but we need to be down training those muscles and letting them relax. We don't want a guarded pelvic floor because it's going to be fatigued, and when we do have that moment that we sneeze, you're not holding it, okay? if we're not engaging soon enough. So most of the studies, when they looked at people with stress incontinence, what they found was they weren't engaging at the right time, okay? Now, I've only got a few minutes left, so I'm going to talk about prolapse a little bit too, because that's an issue that I see quite a bit also. What a prolapse is some of your organs are kind of moving into the vaginal space a little bit. So we talked about losing the collagen and stuff in our vagina. And what happens with that is the integrity of those walls becomes less. And so the bladder's like, oh, hey, there's a little room here. I'm going to kind of scooch on over. The bowels can do the same thing. So your rectum can kind of scooch on over. Our intestines can do that. Our cervix or our uterus can kind of drop down. The vagina can actually fall into itself. And what happens is people don't normally notice this until it gets pretty severe. And all of a sudden it's like, I have this golf ball coming out of my vagina. What's going on with that? Okay, that is a prolapse. Many of us have them or may have not noticed that we have them. And a lot of times they're not going to pick that up when you're getting your standard PAPS test because they're using a speculum and holding the walls back. So unless you say, hey, I'm feeling a pressure down there, nobody's going to look for that. And so, you know, I laugh all the time because I go into my GP and I'm like, yeah, I have 2 undiagnosed prolapses, you know, and she just laughs because she knows what I know. And, you know, and I picked up on that, but I have managed to keep mine under control because if we catch it early enough, we can do some strength training, we can learn how to move better and maximize our pressure control. So the biggest thing I want to tell you before I get kicked off this stage here is that we can do a Kegel. And what a Kegel is you're engaging those muscles at the bottom of the pelvis, okay? I always tell people, I think of it as like taking a milkshake and drinking it through a straw with your vagina. Because you're drawing up and in, you're squeezing it together, you know, and it just, you know, it puts a good mental for me. It works for me anyway. So that's a Kegel, right? Now, if I'm doing one of these and I'm kind of, you know, and my butt cheeks are squeezing, my legs are coming together, that is not a Kegel. Well, it could be. You could be doing a Kegel with it, but we want to be able to do that in church and nobody's going to know you're doing it, right? So pelvic floor only, nothing else is moving. You might have a little tell because your eyebrow lifts, all right? The other thing I want you to know is we have this other muscle that wraps around. It's our corset. It's called the transverse abdominis muscle, and it is a really deep core muscle. And that baby wraps all the way around you, and when you engage it, it snugs you up, and you don't need a corset because you've got your own, okay? That one helps to lift the pelvic floor. They're innervated by the same nerves, so when they work together, they are stabilizing all of you. They're keeping that pelvic floor lifted up. And ideally, if we exhale as well, we're reducing the pressure, reducing the potential for prolapse, for hernias, for other things. And you particularly want to do that when you are lifting weights or doing something strenuous. Engage that pelvic floor, engage that TA, inward, not outward, not the bracing your tummy, and then exhale while you're doing that lift. Okay? Because I think I'm done with time, right? Okay.
Thank you, Dr. Song and Pam. Now Dr. Tran is going to talk to us about sexual health.
All right, thank you, Pam. Yeah, I was trying to Kegel when she was teaching us how to Kegel, and Pam was actually my pelvic floor therapist for, you know, anyway, she was. So I've learned a lot, but I don't always do it, even though I tell my patients to do it. So I'm going to talk about sexual health here. Pam talks about how we don't want to talk about our sexual problems, right? Maybe you talk to maybe your husband about it, but really not wanting to talk to you know, your provider about it. So we're all females here, right? So yeah, still no males. So how often do you guys talk to your providers about your sexual problems? Raise of hands. Anyone dare to raise their hands? Okay. Well, anyway, okay, you don't have to raise your hands. So they did a survey. They did a survey to see how many women or men want to talk to their providers about their sexual health or sexual health problems. And so what did they find? they found that 85% of men and women want to talk to their clinicians about their sexual health. 94% of them says that sexual enjoyment is very important in their lives, but 90% said that they prefer that we, the providers, initiate the topic. So they do want to talk about it, but sometimes, most of the time, they just don't feel comfortable talking about it. So if you had a primary care doctor, if you have a gynecologist, like how often are you telling them, hey, I'm having like low libido, I can't orgasm anymore, like how often are you actually doing that? And then we also hear a lot about men with sexual dysfunction, right? Erectile dysfunction. I mean, I'm sure Dr. Song hear about her men patients all the time. They have low libido, they get testosterone treatment. And what do we get? Like how common is sexual dysfunction for women? And then what kind of treatments are out there? So again, another study. There's always studies on everything. So the studies show that 44% of women reported sexual problems, different types of sexual problems. So we talk about libido problem, we're talking about desire issues, arousal issues, or orgasm issues. So when they look at this number, 44% of women, they say, well, how many of these women are actually distressed by their problems? So when they ask that question, it dropped down to 12%. So not every woman will be distressed if they're having sexual problems. And they notice also that most of these women are aged 45 to 64. So basically the perimenopausal phase, the early postmenopausal phase. And then you're thinking, well, what happened to those 65 and older? Should they have more problems? Yes, I'm sure they have more problems, but they're not distressed about it. So they're really not diagnosed with sexual dysfunction because they probably just gave up by then. So they're just like done. So it doesn't go away. It persists, but it doesn't bother them anymore. So when I think about sexual dysfunction, I like to break it down to 4 different categories. So we talk about sexual desire, your libido is the first one. We talk about orgasms, we talk about arousal, and we talk about pain. So Pam and Dr. Song already talk about that pain, so I'm not gonna go there. So the first one is sexual desire, the low libido. So I Googled or looked for the definition of desire, and one of the definition is an impulse towards something that promises enjoyment. And remember, enjoyment and satisfaction in its attainment. And another definition says a powerful, conscious, or often emotional mental state characterized by longing or craving to obtain a specific object, outcome, or experience believed to bring pleasure. Remember, pleasure or satisfaction. So a lot of us, like, in their 40s and 50s, it hurts to have sex. So why would we desire it, right? Like, why would we desire something that is not, beneficial or painful, or you don't get anything out of it? You're not getting an orgasm, so why would we even desire that? So when we talk about desire, we usually think about 2 different types of desire. So there's the spontaneous desire, and there's also the responsive desire. So we think about spontaneous desire, I would say, think about those guys, like they always think about wanting to have sex, like they just want to have sex. So maybe when you were younger, you would have these spontaneous desires about, wanting to have sex. Those are the spontaneous desire that I think a lot of us feel what desire is. But then you got to think about the responsive desire. So a lot of women have more responsive desire. So that is in response to, say, watching a movie, reading a romantic book, being intimate, just maybe cuddling with your husband or partner. And then, maybe you didn't have desire initially, but then that, hey, once we go there, it's wonderful, you have a good time. So you're like, okay, but you never really just sit there and say, hey, I want to have sex. So, and that's okay. So a lot of women will have that responsive desire. So of course, the women that come to me will say, I have no desire at all. I don't want to have sex. I do everything I can to avoid it. Or what I do, I'm just waiting for it to be over. So that is not responsive desire. So they actually do have some problems. So to have a diagnosis of hypoactive sexual desire disorder, so you have to have the low libido. You don't have the desire, you're doing whatever you can to not engage in that activity. You also have to have it for at least 6 months, and it has to be distressing for you. So I have patients that come in, they have no desire, they don't care, they don't want to do anything about it, it doesn't bother them. So it's actually not a disorder. And I just leave it alone because they don't want anything, they don't want it addressed. And you also have to rule out GSM symptoms. So Dr. Song and Pam talk about painful sex. So you have to make sure that they're not having painful sex, and that's why their desire is low. So if they're having painful sex, you gotta fix that first before you say they have this diagnosis. If you have untreated depression also, And so you got to treat their depression before you actually say they have this diagnosis. And I always tell my patients that desire is biopsychosocial. So the biology part is relatively easy for me to help them with. It's assessing their hormones and making sure that GSM symptoms are resolved. But then I give them homework. I say, hey, there's a big psychosocial component. Things are happening in their life, their poor sleep, their relationship with their partner, their stress in life. So all of that makes a big factor as to why their desire may be low. The next one is arousal disorder and also orgasm disorder. I like to kind of clump them together. And Pam talks a lot about this already. So it's decreased blood flow to down there, right? So arousal is decreased blood flow to your genital area, basically your clitoris. And because of that, it has decreased sensation. And it happens because your estrogen level dropped. So the easiest thing, like Dr. Song, just lather that cream out there. I am more liberal than Dr. Song with that cream. 1 gram for me is from here to here, so not just a pea size. So a lot more does better. So yeah, so estrogen is really your answer. Vaginal estrogen, like Dr. Song said, almost everyone. There are some patients that cannot take vaginal estrogen, but that's a small amount of people. But majority of patients, vaginal estrogen is pretty safe. And then, of course, pelvic floor therapy. It's a big thing, especially with orgasms. So Pam talks about your pelvic floor muscles being very tight. So when it's too tight, orgasm requires your pelvic floor muscles to contract. So when it is too tight, it doesn't contract as much, so then it's harder to achieve an orgasm or it feels muted. And the other way around is true. If your pelvic floor muscles are too weak, then your orgasms become weak also. So definitely use vibrators, and that's why we have someone at one of our tables out there, just showcasing the different vibrators, because I don't see it as a toy. I see it more of as a sexual aid for you to improve your ability to have orgasms when you're having problems. And sex therapy is huge. Besides pelvic floor therapy, I recommend sex therapy for all patients who have problems with low desire. Most of my patients will say, no thanks, they don't want to go, it's too expensive, I think it's just the thought of going to a sex therapist is just kind of like not very interested. But in general, a sex therapist is very helpful, because you have to do the multimodality, right? Like the biology part, I deal with that, but the psychosocial, sometimes you need someone else to help you go through and figure out what is wrong or what else can they help you with. And if you can't figure it yourself, then you need a sex therapist. And of course, if you have a very supportive, engaging, partner, husband, then that is definitely going to be much more helpful. So women's sexual health in general is very important to our overall health. So we find that women with hypoactive sexual disorder desire has an 8 to 10 times more likely than women with normal desire to have problems with unhappiness, disappointment, frustration, bitterness, and also feeling ashamed. So sex is very important to survival of a lot of relationships. They find that when sex is good, it adds 15 to 20% additional value to that relationship. When sex is bad or just not existing, it drains the relationship of positive value by about 50 to 70%. Low sexual desire definitely can affect your self-image and partner relationships. I think Dr. Song mentioned that. So it can decrease your body image, your self-confidence, your self-worth, less connection with your partner, less communication. And I think Dr. Jones had talked about, your partner, because you never want to have sex with your partner, you might worry that they're going to cheat on you. So it is very important for us to discuss women's sexual health. If you are interested or have issues with sexual health, I would recommend that you read Kelly Casterson's book. She has the podcast that Dr. Song had introduced me when I initially had my issues. So this is her book, You Are Not Broken. I also, Dr. Jones and I did meet her also at a conference, I think the Menopause conference 2 years ago. So I also reached out to her. She sent me a couple books that are signed. I think this one is signed, and I think that one over there has a signed copy too. And I highly recommend her podcast and her book if you wanted to read more about sexual desire. That's it.
And finally, Dr. Jones, what are our treatment options?
Thank you. So now that we've talked about all the symptoms that can happen and all the things that we don't want to happen, let's talk about how to treat them. We've kind of alluded to treatment with estrogen already, and that is the gold standard that we want to mention tonight. Now, estrogen is the hormone that's declining, and so that's the thing that if you replenish it, could help a lot of your symptoms. It is not guaranteed to eliminate them, but it can help with all of these. How do we give estrogen? Estrogen can be given through an oral route, a pill, a patch on the skin, which can be applied weekly or twice a week. There's a spray that you can apply on the skin as well. And there is gel, or intravaginally. You can put a ring on the inside, and that can stay for 3 months. We have heard that in the early 2000s, there was the Women's Health Initiative study came out and raised a lot of questions about estrogen. So I get commonly asked, can I take it? Is it safe? Am I gonna get breast cancer? So we'll talk a little about the Women's Health Initiative. That study was not a study that was being performed to check for breast cancer. It was actually being checked to assess whether or not estrogen is beneficial for chronic conditions that's heart disease and cognitive issues and osteoporosis. And they divided the women into two groups. They had women who got estrogen and progesterone. Those women had uteruses and had to be protected. And women who only got estrogen. And they followed them for several years. And the idea was to see if estrogen was going to be beneficial. In 2002, oh my goodness, things fell out of the bucket. The media came out and said that estrogen causes breast cancer because they halted the study quickly before the predetermined time. And so since then, there's been a gap in women's care. But does it really cause cancer? Does it cause breast cancer? No, it does not. The authors have since then came out with studies to assess whether or not the initial results were true. They use something called a relative risk. And we know that to evaluate data, we need the absolute risk. What is the absolute risk of getting a condition? And to put this in perspective, the women who had estrogen and progesterone, they had, versus the placebo, they had a 4 in 1,000 women per year risk of breast cancer. The women who did not had a 5 per 100,000 per year risk of breast cancer. So the difference in estrogen and progesterone was 1 more woman per 1,000 per year. And the absolute risk of that is less than 0.03. So it's very low. But the media came out and said there was like a 25% risk of increased breast cancer because of that one person. So the risk in breast cancer was misinterpreted. Dr. Avram Bruming and Carol Tavris have come out with this book called Estrogen Matters. It's a very good read. Dr. Blumen is an oncologist. He's a cancer specialist. He details his personal relationship with cancer with his family as well. His wife had breast cancer. And he has debunked a lot of the myth about estrogen and breast cancer. And his wife took estrogen as a breast cancer survivor. So that is a book that will help to debunk some of the myths that are out there about estrogen. So yes, for some women who've had breast cancer, it may be an option. It's a discussion with the provider, the oncologist, the type of cancer. For some women, there may be other options that have to be used, other medicines like we call them designer estrogen or SERMs. So there is a toolkit for us to look into for breast cancer survivors and for women who have not had breast cancer. But taking estrogen is safe for women who want to take them and are at average risk. Now, when is the best time to start estrogen? Based on the Women's Health Initiative, we know that the average age in that study was 63. Those women were older women. Those women were mature, is what I like to say. And so they primarily, at that time, had maybe cardiovascular risks. Their blood vessels were already getting thick with plaques, and they probably had memory changes that had solidified. And so they did see some increased risk in those women on the type of estrogen that was used. So we have what's called the ideal window, or the critical window, or the healthy window. And that is within 10 years of menopause, 10 years of your final menstrual period, or preferably before age 60. Now that is a guideline. It's an individualized discussion between the woman and their provider based on their risk and benefits. Because there may be women who are outside that window, who are more mature than 60, who probably have been outside that 10-year window that may qualify for hormone treatment based on their risk and benefits and what they're willing to accept. For the cardiovascular benefits, for the brain benefits, for the bone benefits, and certainly for the vasomotor symptoms that we experience or want to delay, it is worth a conversation. There are other treatments that are available as well that are non-hormonal, because there may be women who don't want hormone or may not be a candidate for hormone for whatever reason. And so there are medications such as antidepressants, anti-anxieties, anti-seizure medicine, some such as Celexa, gabapentin. Those are used to help primarily with the hot flashes and the night sweats. They do not offer the additional benefits for the bone and brain such as estrogen does. For women who have hot flashes, the newest medication on the market are Veoza and Lipicoet, and those work in the brain. The cognitive center is being affected with the hypothalamus, so it turns on the internal thermostat, and that fire that comes up in you when you get the hot flashes, it works. They both work pretty efficiently, pretty quickly, but we do have to watch women's liver during the first year for both of these drugs. And so it is worth discussing non-hormonal options, but hormones are the first line. For women with libido issues, testosterone is a good hormone as well. We find that cognitively, testosterone is beneficial. There are no studies that are there that is showing reversal of cognitive changes with testosterone, and there's no recommendation for testosterone for cognitive benefit. It is only approved for hypoactive sexual desire disorder, as Dr. Tran mentioned. What we have seen, and there are anecdotal studies out there, and some studies that do show that women feel better. They start feeling more energetic, their fatigue is better, their brain fog can improve, because testosterone is a brain hormone, it's a bone hormone, it builds your bone, and it helps in your brain. And so for some women, that may be an option as well to add testosterone. Progesterone is a mood stabilizer. It's a sedative for us. So it helps with sleep. And if you have a uterus, you need progesterone to decrease the risk of thickening of the lining or the inside of the uterus. And it helps women with, sleeping well, because we know the hot flashes keep you up and you wake up at 3 a.m. And so for a lot of women, progesterone works. We ask a lot of times about bioidentical hormone or body identical hormone. I will say that is primarily a marketing term because most of the hormones we use now are estradiol, and that is identical in chemical characteristics to what our body makes. But you'll see on the internet that you have to have body identical or bioidentical. That's what we use preferentially. But it's worth mentioning that some women may not tolerate one formulation or another. Some women may need to try something else, but that is the first line. If you have certain cardiovascular disease or strokes, you may or may not be a candidate for hormones, and you may have to try non-hormonal treatment. The patch is preferred for a lot of women because the oral formulation increases your risk of blood clots, but it doesn't mean that the oral formulation of estrogen is a bad drug. We do use it. There are women who qualify or need to take that to get better benefits. So there's a huge toolkit for us to choose from to help with managing our symptoms. The most important thing is, when do you start? When you're having your perimenopausal symptoms, even if you haven't decided yet to use hormone, it's worth discussing it. You do not have to wait until your final menstrual period to consider treatment. It is not written anywhere that you cannot take hormones that are not birth control pill during your perimenopausal transition. You can be in your 30s or 40s and start having hot flashes, night sweats, mood swings, irritability, all the things. And so you need to have a conversation with your provider at that time. I'll also mention, as a primary care clinician myself, this is not a discussion when you go in to talk about, everything else. I fell off the bicycle and I need to address this injury, and, my mom is causing me stress and I talk about that. This is a conversation by itself. It is important enough where you have to dedicate time, and in a 15-minute visit, you cannot talk about all the things in addition to the menopause things. If you, either with a menopause specialist such as ourselves or your clinician, you will need to take the time to dedicate it because it deserves the attention. It's for our health span, it's for our lifespan, and it's for healthy living for the rest of our life. And it's time for us to talk thinking about estrogen as a prevention and not as a treatment only for things once they've established. Thank you.
Wow. Did you all learn something tonight? That was pretty awesome, huh? Thank you so much. Such a wonderful panel. I'm so thankful that you guys took the time to be here for all of us. And thank you to all of you for joining us tonight. We do have our grand prize winner. We still have to draw. We have a basket here that has 2 signed books in it by the authors, a special tool, and a massage. So our grand prize winner, I know you're still out there to come grab it. We also have, nobody claimed our special secret surprise in the bag over here. So if you have a pink slip in your bag, there is a special surprise in that bag for you as well. And we have more books to give away. So the first person up here, we're having a little book dash. This is another signed copy of this Menopause Moment book. If the first person up here gets this signed one. And, oh, we have a cheater. So again, we have 2 minutes left. Thank you so much to all of you for coming tonight. We certainly appreciate it. And if you'd like more information or an appointment, please sign up before you leave tonight. So safe travels home. Thank you.
Thank you very much for the Menopause Clinic, Dr. Tran, Dr. Jones. I really wow. It's been a great journey for them. Thank you so much for providing that to our service or to our community here.